What I'd like to do now then is to introduce our first speaker, and this is Professor Tony Rudd, National Clinical Director for Stroke, NHS England.
Thank you very much indeed, Chris, and thank you to the organisers for this event. I'm Tony Rudd. I'm a stroke physician working down at St Thomas's Hospital down in London, and I'm the National Clinical Director for Stroke. So any complaints about services, I'm the one to come to. Whatever you may think about stroke services at the moment, I think we should be very grateful that we're living in the 21st century and not the 17th or the 18th century. In those days, if you'd had a stroke, it was called apoplexy at the time, the sorts of treatments that were thought to perhaps be helpful included things like warm, cordial purges, which doesn't sound much fun, or stimulating vomits, and bloodletting was very popular as well. They had some curious ideas, although perhaps not quite as curious as their treatments, around the sorts of things that one should do to prevent stroke, the sort of things which cause strokes. They certainly thought that you should avoid anything which is in the least bit flatulent. You should avoid indulging in too much sleep. So I've told my children that. Don't have a short neck or a fat head was written in terms of avoiding stroke. And of course that obesity is a risk factor, and particularly breathing disturbance, which is associated with short, fat necks. And above all, to avoid extremes of passion, particularly joy. And so no extramarital sex, okay, because that's where the passion is perhaps most intense. So there were some curious ideas about the causes of stroke, about the treatments of stroke. And by the end of the 19th century, William Osler, beginning to bring a bit of science into medicine, wrote about stroke that it is the duty of the physician to explain to the patient or to his friends that the condition is past relief, that medicines and electricity will do no good, and there's no possible hope of cure. In other words, there's absolutely nothing that you can do for it. And when I was appointed as a consultant at St Thomas's Hospital 26 years ago now, that was actually still how stroke was regarded, and Chris has already mentioned what it was like when he first qualified. I was a few years after him, not that many. Often stroke patients wouldn't be admitted. What was the point of coming into hospitals? General practitioners said to me, if you're not going to do anything, and they were right. When people were admitted, they came into a general medical ward where they were taught on maybe once or twice, and then they gradually migrated down to the end of the Nightingale ward so that the ward round didn't have to actually touch them on the way round. They did receive some rehabilitation under the geriatricians if they were old enough to qualify for a geriatric wards. If they were too young, then actually they got really nothing. There was virtually no care in the community. If you had a TIA, and we've heard a lot about that today, a fantastic publicity campaign from the Stroke Association, you would wait for months to see a specialist. And having waited months to see the specialist, you would wait for months to have your investigations done. And trying to get a brain scan for somebody with a stroke was sometimes extremely difficult. I had only just started as a consultant. I had a patient who came in with a stroke, and I wasn't doing brain scans routinely on patients in those days. They were quite difficult to get, as I've said. But I decided that in this particular case, it was really important that we had a brain scan. So I asked the team to send a form down to request the scan, and a couple of days later, because that's how long it took for the form to get to the X-ray department, it came back scrawled across it, stroke, scan not indicated. So I said to the registrar at the end of the ward round, would you just go down and explain in a bit more detail to the consultant radiologist why a scan is important for this particular patient? And he came back half an hour later, a bit sheepish, and said, well, I've spoken to him and he's absolutely adamant. So I thought, I'll go down and have a man-to-man chat with him and explain. So I walked into his office. He stood up, he looked very angry, and then he hit me in the face and said, I've already explained to your registrar you're not having a scan. Now, I have not been hit by a consultant since then. Okay, I now get scans without being beaten up. So I know that services are improving. Things have changed. Stroke mortality has fallen by about 60% over the last 20 years. That's largely down to things that the general practitioners are doing, that public health is doing in terms of treating better hypertension, people smoking less, and so on. But it's also in part due to better quality care. We've had some really important bits of stroke research reporting, much of it funded by the Stroke Association. So probably the most important piece of research was showing that stroke units, if you get admitted to a stroke unit, your chances of surviving your stroke and the chances of surviving with less disability was significantly greater than if you were managed on the general medical wards that I described earlier on. There was the demonstration that giving people aspirin, a simple drug that's been around a long time, is beneficial in the early stages of stroke, probably in preventing further strokes. More recently, there's been the evidence showing that clot-busting drugs, which have been used for many years for heart attacks, actually benefit people with ischemic stroke as well. And that's been really important in terms of driving the improvement in services, because if you're going to give thrombolysis, you have to do it really quickly. Maximum of 4.5 hours, but the quicker the better. And in order to do that, you've got to have people in hospital, and you've got to have had them scanned, and you've got to have had them seen by an expert. There's been the evidence around community care, getting people out of hospital earlier and treating them with a specialist team in the community. Early supported discharge is what we call it. Also, surprisingly, actually reduces mortality and certainly improves outcomes and provides a service which is of lower cost than keeping people in hospital if you're worried about the finances, and of course we are. There's evidence around the fact that therapy, the amount of therapy that you give matters, the intensity. And there's been lots of research around stroke prevention, and that includes TIA. So the research has driven the service improvements, and perhaps one of the most useful bits of service improvement has been around the development of stroke as a specialty. It is now possible for young doctors to decide that stroke is what they would like to do for the rest of their careers, and that's been really important. And there's been similar specialist training for nurses and therapists as well. We've had national audit, which has been very powerful in terms of showing where we are. So we started auditing at a national level back in 1998, and the early findings were that actually services were pretty disastrous. And that showing that services were bad has been really useful in terms of showing what we need to do and persuading people to change. So as a result of those sort of data, we got the politicians finally interested in stroke, and we had the National Stroke Strategy published back in 2007, also really important. So there have been lots of policy things, lots of things driving improvements, to the point where now every hospital in the UK has a stroke unit, and getting on for 90% of stroke patients will see that stroke unit during their admission. And that is higher than any other European country or any other country in the world actually achieves in terms of delivering stroke unit care. We've got access to thrombolysis for virtually the whole population now. And we are thrombolysing something like 11 or 12% of all stroke admissions, which may not seem very high, but actually it's higher than, again, virtually any other country in the world, apart from maybe some of the Scandinavian ones. And we've seen that reconfiguring stroke care, particularly for the acute care, getting patients into a centre where a comprehensive stroke centre, where they can have immediate access to the experts, regardless of the time of day or the day of the week, has also been important, and Manchester has led the way on that, as well as London. But I'm not being complacent. The job is very far from being completed. And there is a real concern now that actually people think that stroke care the problem has been solved and they can move on to something else. There's still huge variability in the quality of stroke care around the country. There are still units where you really would not even want your mother-in-law admitted. There are still problems in terms of getting access to certain sorts of care, like thrombolysis, out of normal working hours. There are huge problems in terms of getting access to longer-term rehabilitation, getting access to psychological support, and so on. And we have to deal with that. There are problems with getting enough therapy to people. There is still the issue that patients go into a stroke unit and they spend 23 hours of the day sitting around doing not very much. So we've got to deal with those things. I spend some of my time going to other countries looking at stroke services, and I've been in China and Vietnam in recent years, where, again, it brings home to me the fact that we have made fantastic progress compared to other parts of the world, but emphasizing really, again, that we need to continue to develop. It's been very nice working in those countries, Vietnam and China, because they have communist governments. And if they decide they're going to do something, if they're going to change their stroke services, they just do it. None of this consultation with patients. So they make up their mind what's needed and they go ahead and do it. I'm being slightly flippant. So, in summary, I think that we have made progress. Prevention I have not concentrated on, and it really is important. It's the most important thing that we do. Probably 70% of all strokes are preventable. If we managed hypertension, if we got everybody's blood pressure down to really low levels, if we stopped everyone smoking and so on, the vast majority of strokes would be avoided. And that's true even once you've had your first stroke. It's really important to make sure that you are properly treated in terms of the advice and the lifestyle changes that you adopt to prevent yourself having further ones. Clearly, further strokes are dangerous, and Napoleon's physician said that a first attack, referring to stroke, which is often slight, is a summons without cost. Not really true, but for some it may be. A second stroke is a summons with costs, and a third is an execution upon the person. And I was reminded of that quote when I was walking over Westminster Bridge to go to a BBC studio to give an interview after Princess Margaret had had her third stroke, the celebrity that Chris was asking for, not necessarily the one that was going to engender the greatest amount of public sympathy, but nevertheless. So I got a phone call on my mobile as I was walking across the bridge, and the producer of the news program said, "Thank you very much for coming over to give this interview, and we particularly liked the statement that you made, 3 strokes and you're out, and we'd be grateful if you'd perhaps use that statement in your interview." Of course, I'd said nothing of the sort. There was an element of truth in it, but if we tackle stroke properly in terms of prevention and subsequently treatment, I'm sure we can radically improve the lives of many stroke patients. Thank you very much.